start off with hepatitis B. Hepatitis B is actually a virus that causes inflammation of the liver. And I think all of you are very familiar with the different types of hepatitis virus. You have heard of hepatitis A, B, C, D, and E. So hepatitis A and E are actually acute causes of acute hepatitis, meaning that the hepatitis that actually are caused by A and E are short-term, and the patients usually recover by themselves. And these diseases are transmitted by food only, okay? And hepatitis B and C are what we call chronic hepatitis, where the patients with infection of such viruses can have sustained inflammation over a long period of time. Hepatitis B and C are transmitted by body fluids. Hepatitis D will only happen when the patient already has hepatitis B. Hepatitis D doesn't happen by itself. So hepatitis B is transmitted by contact with contaminated blood products, and other body fluids, including semen. Okay, and this can happen during dental or medical procedures, during blood transfusion, during injection of drugs, tattooing, acupuncture, unprotected sex, and during childbirth. So one of the common methods of transmission is from mother to child during childbirth. So as you can see here, the worldwide prevalence of hepatitis B virus infection, the highest rates of hepatitis B is actually in the African continent, okay, and then followed by Asia. So in Singapore, there were about 6% of Singaporeans who are hepatitis B carriers. And as mentioned before, in the local context, the most common means of transmission is at birth from a mother with hepatitis B to the baby during the blood exchange at the time of the childbirth. And the risk of developing chronic hepatitis B is more than 90% if it is transmitted at the time of birth or when the child is very young. And if, let's say, it's acquired as an adult, most of the time the hepatitis B will be an acute version, and only less than 5% of these patients will have chronic inflammation from hepatitis B if they get it as an adult. So this diagram summarizes the acute versus the chronic hepatitis B. So patients with hepatitis B can present either as the acute form or the chronic form. Acute hepatitis B is defined when a patient has never had hepatitis B before and is now diagnosed with hepatitis B. And when this patient is followed up after 6 months, at 6 months, the blood test for hepatitis B is negative. So in this case, we'll classify the patient as having acute hepatitis B. So chronic hepatitis B will refer to patients when the hepatitis B infection persists for more than 6 months. So there are various ways to test it. So we use certain blood markers like hepatitis B surface antigen. We look at the liver enzymes. We also look at the hepatitis B virus DNA, which is the genetic content of the virus in the blood. So there are many people who are hepatitis B carriers, and these patients feel very well. They have no symptom, and if they do not check, they do not know that they have hepatitis B. So these are hepatitis B carriers. So the patients with acute hepatitis B can present with symptoms. So this means that this patient has a very acute inflammation of the liver. They can present with pain in the right upper part of the abdomen. They can present with lethargy, nausea, fever. Anorexia, which means poor appetite. That means they have no appetite. They can present with jaundice. Jaundice refers to the yellowing of the skin and the white of the eye. So that means if the patient looks in the mirror, the white of the eye becomes yellow and the skin is yellow. Okay? Then chronic hepatitis B, basically, as I mentioned before, refers to infection that lasts for more than 6 months. And in many of such cases, they persist for the entire lifetime. So this cartoon tells you the presentations of acute and chronic hepatitis B. So in acute hepatitis B, they can present as acute asymptomatic. That means they have acute infection, but yet they feel well. They don't feel anything. They can also have acute symptomatic infection, presenting the symptoms that I mentioned in the previous slide. And the most serious forms will be the acute fulminant hepatitis. So fulminant hepatitis means that there's a very sudden deterioration in the liver function, where the patient gets confused, they turn yellow very fast, they can get kidney failure, and this can be life-threatening in some instances. And for patients with acute fulminant hepatitis, a lot of times if there's no liver available for transplant, they may actually die from it. So it's a possibility that death can happen in acute fulminant hepatitis B. So for patients with chronic hepatitis, as mentioned, most common version is actually the carrier status, where the patients feel very, very well. They can also have chronic hepatitis B, where there's liver inflammation, and these are the patients where if we do the blood check, we will see that the liver enzymes are abnormal. The AST and the ALT level, which are the liver enzymes, will be high over a sustained period of time. So these are the patients with chronic hepatitis. And long-term inflammation of the liver will lead to hardening of the liver, and this then causes liver cirrhosis. So how I explain to my patients what is hardening of the liver is usually, if you imagine the liver is usually like a sponge, it's very soft. So as the liver gets damaged, over time more and more fibers like raffia strings will grow into the sponge. And over time then, as more and more of the fibers grow into the liver, then the liver will get harder and harder. And the final stage of the liver hardening is called liver cirrhosis. And with liver cirrhosis, then the chance of liver cancer will also increase with the long-term inflammation and the liver hardening. So of course now hepatitis B is actually declining worldwide. Why? Because of hepatitis B vaccination. Okay, as you can see from this map, almost the entire world has now got a vaccination program for hepatitis B in their health schedule. However, the implementation is not ideal in many countries. So as you can see here, only some countries have got more than 95% coverage in terms of a full schedule of hepatitis B vaccination. And therefore, this indicates that more can be done in many, many countries to further improve the vaccination rate for hepatitis B in many of these countries. So in Singapore, we're very fortunate that in Singapore, hepatitis B immunization for infants born to hepatitis B carrier mother was started in 1985 in Singapore. And this was extended to all newborns born in Singapore in 1987. So that means all of the people who are born from 1987 onwards, by default, would have received the hepatitis B vaccination at the time of childbirth. And you can see here on this graph that at the point of implementation of the vaccination at childbirth, the rate of acute hepatitis B also declines. So it is obvious that hepatitis B vaccination is a very useful method to prevent hepatitis B infection. So despite the fact that hepatitis B has been declining due to vaccination, we as doctors still have to manage the problems of chronic inflammation caused by this hepatitis B vaccination. So what can happen? Acute infection can happen, and if they are acquired at childbirth or at a very young age, more than 90% of these will proceed to chronic infection. As you can see here, chronic infection can lead to liver cirrhosis in 20 to 30% of these patients who have untreated chronic inflammation, okay? And these patients with cirrhosis will then have a higher chance of liver cancer. But it's also important to note that patients with chronic infection can also get liver cancer without developing cirrhosis. About 5 to 10% of patients with chronic infection can actually get liver cancer without even developing liver cirrhosis. And patients with liver cirrhosis, about a quarter of these patients will eventually decompensate within 5 years. When we talk about decompensation, we mean that they get complications of liver cirrhosis. So complications of liver cirrhosis will include things like ascites, which is a collection of fluid in the abdomen, where the abdomen gets very swollen. They get a lot of water retention with swollen abdomen and swollen legs, and even fluid in the lungs, okay? And some of them may need medication or measures to draw out the water. They can also get things like bleeding because of the increased pressure due to the liver hardening in the vascular system. They can get swollen vessels in the esophagus or the food pipe, and they can actually end up with vomiting of blood. And because the liver is involved with removal of toxins in the blood, so patients with liver cirrhosis can also get what we call encephalopathy, or where they get like a confusion because of the fact that toxins are not removed, and then it affects the brain. So we would therefore want to prevent such things from happening, and we want to manage the condition as early as possible. And a lot of these patients may eventually need liver transplant. If they don't get it, then they may actually die from a very severe liver disease. So you can see from these charts that the risk of getting liver cancer increases with increasing viral load. That means when we check the blood for the hepatitis B virus load, the higher the load, the higher the risk of the patient subsequently getting liver cancer later in life. So now we talk about how to assess for liver hardening or fibrosis. Decades ago, the method that was used to diagnose it was liver biopsy, where the needle has to be poked in and the cell has to be taken out and then look under the slides for liver changes. However, now with advancement in technology, there are other non-invasive methods to do the assessment. So one of the methods is actually shear wave elastography. So this actually is somewhat like an ultrasound, if you are familiar, it's something similar to ultrasound examination, where a shear wave is actually produced, and then the propagation of the wave is then measured and then translated into certain numbers. And then this can then be used to interpret, to translate into the level of fibrosis in the liver. Okay, so this complicated table is basically to tell you that not all patients with hepatitis B has to be treated. And when to treat and how to treat is not a simple decision. It is quite complex. And so for patients with complicated liver condition, like very complicated hepatitis B, then they should see a specialist, because then the specialist will explain and decide on whether the treatment has to be initiated and how it can be treated. So the hepatitis B treatment has evolved over the years. It started off as an injection called interferon, and then into this drug called lamivudine. Lamivudine has got a problem because it has got a very high level of resistance. That means the virus developed resistance to lamivudine quite quickly. So therefore, lamivudine fell out of favor. Then for adifovir was a problem also because of renal issues, kidney issues that it can cause. And then a new injection called PEG interferon, and later newer drugs like entecavir, tabivudine, tenofovir, etc. So this drug called tenofovir has got a newer version that is superior to the older version, because this drug is acting more on the liver and less of it goes through the kidneys. So because of that, the dosage that's used is less, and therefore the toxic effect is less. So this summary tells you that certain drugs have fallen out of favor because of the fact that they're not potent and they have got higher chances of resistance. So currently in the markets, there are a few options which we use to treat, and again, the doctor will be the best person to advise you. So this table is just to tell you that there are options available, some good, some not so good, and the doctor will advise you which one to be used. So follow-up for patients with hepatitis B who are not on treatment, usually they should be monitored regularly for their liver enzymes, for the tumor markers, which is the alpha-fetoprotein, is a blood test, as well as ultrasound examination, because if the ultrasound picks up a liver mass on the ultrasound, then it has to be further investigated. So this gives you a summary of how to follow up a liver mass. If the liver mass is very small, less than 1 centimeter, usually the patient can have a follow-up ultrasound examination, usually 6 to 12 months later. If the mass is very big, then they will need further imaging using a more advanced method, such as a CT scan or MRI. And this is what it looks like. The top 3 are the MRI images of the liver tumor, and the bottom 3 are the CT images of a liver tumor. Okay, so this is a rather complicated summary of how liver cancer can be managed. But again, the message here is that liver cancer management is complicated. Usually it's not decided by one single specialist. It's usually decided by several specialists, including gastroenterologists, hepatologists, the surgeon, the oncologists, the radiologists. So there are methods such as tumor resection. There are ways to insert a needle, to burn it. There are ways to inject certain drugs to the tumor itself. And there are also chemotherapy drugs, okay? And chemotherapy has advanced, and this is really in the realm of oncologists. If needed, the oncologist will also discuss with the patient, because several factors have come into play, where how costly is the drug, what is the life expectancy, and various other factors, side effect profile, etc. So again, not a simple decision. So I finished the talk on the hepatitis B. I will now proceed to talk about Helicobacter pylori infection. So as our MC told us just now, Helicobacter does not refer to Helicobacter. Does not refer to helicopter. Helicobacter is actually a bacteria. It's a bacteria that can affect the stomach in some patients. Okay, so basically it is a bacteria that resides predominantly in the stomach, And in a lot of people, they do not have any symptoms. So that means a person can be carrying Helicobacter and yet he feels well for many years, okay? And actually, Helicobacter pylori infection is rather common. So you can see in this chart that about half the world or half of the population in Asia could possibly have been infected with Helicobacter at some point in their life. And in Singapore, a study done many decades ago put it about 40+%. So Helicobacter actually attacks the lining that protects the stomach. And these bacteria produce an enzyme called urease. And this urease is actually the bacteria, the enzymes, sorry, the urease is the enzyme that we use to help with our diagnosis, which I'll explain to you later. So this urea, the urea is broken up by this enzyme called urease, and it produces ammonia. Okay, and this ammonia will then change the pH and then increase the chance of the organism surviving in the very acidic environment of the stomach. Okay, and the ammonia, besides increasing the pH, also directly damages the cell of the stomach wall. So Helicobacter is actually an infection. It's an infective disease, which means that it can be passed from person to person. So meaning that, and studies have shown that there tend to be familial clustering. That means if one member in a family has it, it's likely that other members in the family may also have it. It is not because it's genetic, because it's totally not genetic, but it's because family members have close contact, they share food, they share cutleries, and therefore if one person has it, they can pass it to the next person. It can also be from contaminated water or contaminated food. So why is it so important to treat Helicobacter? Because Helicobacter is a cause of gastric cancer. And in fact, WHO, World Health Organization, classifies H. pylori as a class 1 carcinogen, meaning it's a class 1 cause of cancer, similar to the way smoking causes lung cancer. Both are class 1 carcinogens. Okay, so in the whole world, the highest rate of gastric cancer is actually in China, Japan, and Korea. Besides causing stomach cancer, Helicobacter also increases the risk of a type of lymphoma of the stomach called the gastric mold lymphoma. It also increases the chance of getting ulcer disease of the stomach. Okay, and this, therefore, based on guidelines, it is very clear that if the patient tests positive for Helicobacter, they should definitely be offered treatment. They should be offered treatment for the Helicobacter. So if you look at the flow chart on the left side, Helicobacter increases gastritis or inflammation of the stomach, and this leads to atrophy. Atrophy means that the stomach wall becomes very thin because of the damage. And over time, they can get this change called intestinal metaplasia. Intestinal metaplasia refers to a change at the cell level where the stomach cells changes due to the long-term damage and now looks like the intestine cells. Okay? And this is called intestinal metaplasia. And this will then lead to the higher risk of progressing to the next stage, which is called dysplasia. Dysplasia is basically the last step before cancer, and then finally cancer. So basically, you can see from this chart that patients with gastric atrophy, which is the thinning of the wall, as well as intestinal metaplasia, has a higher chance of getting cancer. You can see here that the cancer risk is increased when the patients have atrophy and intestinal metaplasia. And of course, the risk is much higher when they have dysplasia. You can see the last row, for patients with high-grade dysplasia, the chance of them getting cancer in 5 years is actually 60 to 85%. Okay, so Helicobacter is definitely a known cause of cancer. The other thing I want to tell you is that if the Helicobacter is treated at the stage before intestinal metaplasia and before the gastric atrophy stage, if it's treated, then the chance of cancer returns to 0. That means it's baseline. If the Helicobacter is treated after the changes have happened, that means when there's already intestinal metaplasia and dysplasia, then the Helicobacter is removed, the cancer risk is still going to be there. So therefore, the earlier you diagnose and earlier you treat the Helicobacter, the better. Okay, so the Academy of Medicine in Singapore, based on the statistics, have actually recommended that patients with risk factors like intestinal metaplasia and previous H. pylori infection should have regular surveillance or screening of the stomach with an endoscopy at intervals based on the risk factor profile. So now, how do we diagnose Helicobacter? Helicobacter can be diagnosed based broadly into 2 broad classes of methods. One is the non-endoscopic test. The other version will be through endoscopy. So if we are not using endoscopy, we can use blood tests. We can use the urea breath test. We can use the stool or the fecal antigen test. By and large, blood test is not a good way to diagnose Helicobacter. If you do health screening, sometimes you'll see that health screening will have this blood test for Helicobacter. It tests for this thing called immunoglobulin G of Helicobacter. The reason why the blood test itself is not good is because IgG can be high when the patient has got previous Helicobacter but is now no longer positive for Helicobacter. The other thing is that there's this thing called cross-reactivity. That means sometimes the antibody that is tested for may be actually against another organism, not against Helicobacter, because no test is 100% accurate. So in general, it is not advisable to treat based on blood serology alone. Okay, so the other two tests, like urine breath test and fecal antigen test, are very accurate. So we talk about the breath test first. So for the breath test, the patient, first of all, has to be fasted, no food, and then the patient will come in, blow into a bag, and then after that, they will take a special capsule with a urea in it, and then they will wait for 30 minutes, then they will blow into a second bag. And then now both bags are then placed on the machine, and then the result will be generated, whether the patient has Helicobacter or no Helicobacter. So what is the theory behind this? So basically what is ingested by the patient, right, has got a carbon labeled, usually 13 or 14 labeled carbon in the urea. And when the patient ingests this, if there's Helicobacter, then the Helicobacter produces ureas, and the ureas will then break down the urea. Okay, and the carbon, which is labeled as 13 or 14, will then be breathed out as carbon dioxide, which is labeled as 13 or 14. And that's how the machine picks up. And if the carbon 13 or 14 labeled CO2 is high, then it indicates that there is Helicobacter. So the stool antigen test is basically just collect the stool and you drip it into a reader, and then you indicate whether you have or do not have the Helicobacter antigen. So now we go on to the endoscopy method. So endoscope refers to a flexible tube with a camera that allows us to look in the stomach. So we'll insert the camera through the mouth, and it goes down the food pipe of the esophagus, and then into the stomach, and into the beginning of the small intestine. When in the stomach, I can then take tissue. I can then take tissue out from the stomach, and then I put into the gel. Okay, so for this procedure, patients are usually asleep. So they'll be very comfortable, they'll be sleeping, they will not be struggling, and then that gives us a lot of time to just take the necessary tissue for testing. So after I take the tissue, I put into a gel. This gel is basically made of this chemical called phenol, okay? And this phenol will change the color when the pH changes. So as you are aware, I mentioned to you before that urease breaks down urea, okay? When urea is broken down, it produces a change in the pH such that the acidic environment becomes more alkaline. And with the change in pH, the color changes. So you can see the top one is yellow, that's the original color. When I put the tissue in, if it changes to pink or red, then it indicates the bacteria, Helicobacter, is present. The third method, or the other method, is to basically use the stomach tissue and send it to a lab where they will stain the slides. Under the microscope, they will look for the bacteria. If they see the bacteria, that means the patient has Helicobacter. Helicobacter can cause peptic ulcer. So this is what ulcers look like when we do the endoscope. And one of the complications of ulcers is that they can bleed. Okay, when it bleeds, we can treat them during endoscopy by various methods. We can spray certain substances to stop the bleeding. I can put clips. I can also burn it with certain equipment and using the heat and the burning, they will stop the bleeding. So this is how examples of how the stomach tumor look like. It can present as a growth. It can also present as ulcer. Okay. So how do we then treat Helicobacter infection? So the first thing is like what I mentioned. The first thing is to prevent. So to prevent, we should therefore practice good hygiene methods. We should practice good hand washing. We should avoid raw material. And if let's say there's already a known person in the family with Helicobacter infection, it should be treated. And before it's been eradicated, then you should avoid sharing food with this family member. Okay, so this table is just to tell you that the treatments are available. In general, most of the time, it consists of 3 drugs. The first drug is a medication to decrease the acidity, and then this is used in combination with 2 antibiotics. The duration is between 7 to 14 days. The trend now is to use 14 days because studies have shown that if you use a longer duration of 14 days, it increases the success rate marginally, okay? And the success rate is not 100%. It's not 100%. Most studies will, depending on the regime used, give a success rate of between 70 to 90%. Why is it not 100%? It's because there's a chance of resistance. That means some of the bacteria are resistant to certain antibiotics. As you can see here, in some regions, the bacteria is resistant to certain antibiotics as much as 60% of the time. So therefore, it is not 100% success. So then, how do we then diagnose cancer? Of course, when we see a mass, the first thing is to do a biopsy, because the gold standard is still to diagnose based on what we see on the slide, the histology. There's also another way to stage, besides scanning, is to use a special technique called endoscopic ultrasound, where the ultrasound probe is placed right next to the tumor in the stomach. And using that, I can actually see the depth of the involvement of the stomach tumor. Okay, so this will require special training, and I've got this training to do this procedure for 1 year in Germany. So the next one is actually scan. So CT scan can also be used to stage to see how far it has spread. So you can see the top two pictures are example of a tumor that's caused a blockage. Can you see the stomach is very, very big? Because the food content and the liquid cannot escape from the stomach, because the outlet of the stomach is blocked by the tumor. Okay, and the last one shows that the tumor, the last scan at the bottom shows an example of a perforation, meaning the gastric tumor has eroded through the whole wall of the stomach, and because of that, the stomach contents have leaked out into the space in the abdomen. Okay, so in conclusion, patients with hepatitis B has an increase of liver cancer, and therefore hepatitis B patients should be followed up, and some of these patients should receive treatment. Helicobacter also increases the risk of stomach cancer, and these patients should definitely be treated. Okay, thank you. Any questions you want to ask me? There's a question here. It says, is biopsy the best way to test your liver if ultrasound is done and inconclusive? Okay, so it depends on what you, okay, so there are a few questions here that we're trying to answer. Number one, it can be whether the liver has fibrosis, right? The other possibility is the ultrasound shows a mass, and you want to know whether the mass is a cancer or not cancer. Okay, so let's say with the first scenario, when there's a suspicion of liver hardening. For example, a patient with hepatitis B has an ultrasound done, and the ultrasound sometimes report that the liver looks a bit rough. Sometimes the ultrasound reports that it looks a bit rough. So does it always mean that in such cases it's liver hardening? No. Why? Because ultrasound by itself is not conclusive. So then usually, currently, liver biopsy is usually not used yet, unless the patient is very sick and we need definitive data very quickly. Usually we use non-invasive method, and one of the methods that I mentioned is actually the shear wave ultrasound. There are also some other blood tests, so-called blood panel, where they actually take certain parameters and then they calculate a score. So these are all the various methods that we can use. But by and large, the one that's been recognized a bit more, the non-invasive method, is the shear wave ultrasound. So with that, then that will tell us whether or not the patient has got hardening. There's another time where we may use a liver biopsy is when patients present with liver inflammation. For example, the liver enzyme is very high, maybe in the region of thousands. Patient is very sick and ill. We have done all the blood tests. We have done all the usual blood tests for viral blood hepatitis, autoimmune. We have gone through the drugs, drug list of the patients, and we cannot find the source or the cause of the liver inflammation. In such cases, then we may proceed to do a liver biopsy, because sometimes the cells on the biopsy can give us an idea of what is the cause of the liver inflammation that the patient is having. Okay. Then the third case scenario will be a case when a mass, that means they do ultrasound and they find a mass on the ultrasound in the liver. So now, is this mass cancer or not cancer? Okay, so the first step to take is not to do a liver biopsy. In such cases, the first step to do is to do another better imaging method, which is either a CT scan or MRI. And liver cancer is unique because it is about the only cancer that allows a diagnosis of cancer to be made without biopsy. Okay, liver cancer is about the only cancer that can be diagnosed without a histology. That means if a CT or MRI shows very, very clear characteristics of a liver cancer on the scan, and on the background of a risk profile of the patient, and a very high tumor marker, that means the alpha fetoprotein is very high, then there's no need for a liver biopsy. There's no need for a biopsy to get a diagnosis. Okay? There are cases where it's inconclusive, meaning that there's a mass, you do a CT, you do an MRI, you still do not know what it is. Then in those cases, a biopsy can be done. There will be a targeted biopsy guided by a scan where they'll target the mass and take the tissue for testing. Yes, so in such cases, we will do a liver biopsy. So have I answered this question, whoever asked it? Okay, yeah. Then the next one is, I was given triple therapy when I had H. pylori in 2007. What is the best test to confirm that I don't have it? Okay, so the current best test now for you, if you are feeling well with no symptom, is just to do a urine breath test. You can also choose to do the stool antigen test, but I think most of us prefer to blow into the bag rather than collect the stool. So I think most people will still prefer to do the urine breath test. Okay, so you can do a urine breath test. Okay, so if I did get hepatitis B vaccine at birth because it's born before that period, then should I get tested for hepatitis B? Okay, so yes, you can just do a blood test to check, number one, to check whether you are hepatitis B carrier, and number two, whether you have antibody. If you have no antibody and you are not positive for Hep B, then you should get vaccinated. Vaccination consists of 3 jabs. Okay, the first jab is at 0, second jab is at 1 month, third jab is at 6 months. So the complete course of vaccination for hepatitis B is a 3-course injection. Okay? Okay, if suspected Helicobacter and has acid reflux since 30 years old till now, omeprazole didn't clear the acid reflux. What to do next? 70 years old already. Okay, so in general, as we grow older, the chance of cancer of any sort increases. So a 20-year-old and a 70-year-old who present with the same symptom of stomach pain, etc. Okay, 20-year-old, we will place cancer at the bottom. For a patient who is much older, cancer is always going to be on our mind. So if it's a 70-year-old lady who has persistent symptoms despite being treated with omeprazole, please see a specialist, see a doctor, okay, or a specialist, and then discuss and then see what's the next step. Yes, endoscopy may be needed depending on your actual symptom and what has been done so far, okay? How frequently should seniors over 50 do endoscopy? So, okay, endoscopy is a general term. Endoscopy just means anything with a camera. It can mean a nasal scope, it can mean a stomach scope, it can mean a colonoscope, it can mean a capsule endoscope. So I assume here the endoscopy the person is asking is about stomach scope. Okay, so commonly the most common endoscopies done for most people is the gastroscope, which is the stomach scope, and the colonoscope. So now in Singapore, there is no guideline on when to start screening with a stomach scope. In certain countries, like in Korea and in Japan, yes, they do have, because the cancer rate is much higher. In Singapore, currently, there's no guideline to say that you have to start doing a stomach scope at a particular age. So currently, it is based on symptoms. If a patient has got risk profile, family history of cancer, now presenting with stomach pain that's persistent despite medication, yes. So endoscopy decision is based on symptom and risk profile for the stomach. For the colon, it's different. Colonoscopy screening, okay. Colon cancer screening in Singapore now recommended to start at 50 years old. 50 years old. In the United States, they have shifted the age now to 45 years old. Why? Because the data has suggested that although in recent years the cancer or colon cancer rate has dropped, but in young people, when they do a sub-analysis in the younger age group below 50, the rate is actually increasing. The rate is actually increasing. So therefore, based on that information, they have shifted the screening age for colon cancer down to 45 years old instead of 50 years old. Colon cancer screening usually consists of a few things. Commonly, I think all of you are aware you can do a stool test for blood. Stool test for blood. That has been done yearly. The other way to do it is to do a colonoscopy. Okay, colonoscopy need not be done yearly. Usually you do one at baseline depending on whether it's normal or whether there are polyps, the size of the polyps, number of polyps. Then the next colonoscopy will then be decided. The doctor will advise you based on what he finds. Okay. How will the H. pylori be taken during gastroscopy? Okay, so I presume this question is asking, how can the tissue for testing H. pylori be taken during gastroscopy? So basically during gastroscopy, the scope itself has a channel in it, and in the channel, I can put in certain equipment, including forceps for biopsy. So usually, routinely, when I do the gastroscopy, I will put the forceps in to the gastroscope, and then I will take a stomach tissue and put into the gel for the urease test, the yellow gel, that turns pink if it's positive. I routinely do that. In some cases where the stomach looks a bit more red or there are ulcers, then I will take additional tissue for histology, which is to look under the microscope. Okay. Is biopsy the best way to test your liver if ultrasound is done and inconclusive? I think I've answered this question a similar question just now, okay? I think this question is asking for hepatitis B. If you dine with a person, can you get infected? I think. So hepatitis B is transmitted by body fluid. So that means it's primarily through blood and sex. Through blood and sex. Can it be transmitted through saliva? Theoretically, it's not impossible, but it's very unlikely because the viral load in the saliva is very, very, very low. So it is not impossible, but it is unlikely to be transmitted through food. Okay. Mainly it's through sex and blood, okay? So for those with IBS, do they have higher risk of stomach or other? Okay. IBS is irritable bowel syndrome. There's another called IBD. A lot of patients confuse IBD with IBS. IBD, I think Dr. Chong will talk about IBD later, but I'll just briefly tell you IBD and IBS, the difference is IBS stands for irritable bowel syndrome, IBD stands for inflammatory bowel disease. IBS has got no inflammation. It's a syndrome based on symptoms. That means the patient has got maybe stool problem, diarrhea, constipation, then a lot of abdominal bloating, gas. So these are the symptoms that forms the syndrome of irritable bowel syndrome. So irritable bowel syndrome doesn't increase the risk of cancer. It doesn't have any, that means when we do the check, we do the scan, we do the scope, the result will be normal. But yet the patient has a lot of symptoms. So that's called irritable bowel syndrome, IBS. So IBS does not increase the chance of cancer. IBD, which is inflammatory bowel disease, means that there's inflammation of the digestive tract. And patients with IBD has got a higher risk of getting cancer of the digestive tract, okay? So, can H. pylori cause long-term effects? Yes. H. pylori can cause long-term effects. I've got one slide before that I mentioned that H. pylori increases the chance of stomach cancer, stomach ulcer, gastritis. So, but having said that, a lot of patients can have H. pylori for a long time, and yet they may not feel anything. So it's possible that patients may have H. pylori with no symptoms at all. Will constant consumption of alcohol lead to liver hardening? Definitely. Alcohol is definitely one of the responsible agents that lead to liver hardening for sure. Does hepatitis B vaccination protect you for life? Okay. As with all vaccines, the effect of the vaccine will wane over time. So even if you have vaccination at birth for hepatitis B, it doesn't mean that for life your hepatitis B level protection will stay at the high level. So over time it will drop. So for us healthcare workers, we sometimes at the time of renewal of license, etc., we may be asked to check for our hepatitis B status and the antibodies. Because if it's too low, then we will have to revaccinate. So hepatitis vaccination, as with all vaccination, the effect will wane over time. Okay. If I had H. pylori and cured, do I have to check every year? No. Helicobacter pylori infection is an infection, meaning that you have it, you cured it, then it's over. However, H. pylori infection does not confer immunity, meaning that if you have H. pylori infection before, it doesn't mean that you'll never get it again. If you've had it now, then you can get infected from another person, then you have a re-infection with a new episode of H. pylori infection. Okay? And then one last question. Is FibroScan a good test for liver issues for hepatitis B carrier? FibroScan is actually elastography. FibroScan is just a brand name. Elastography, there are many, many companies with different machines. So elastography is a technique. FibroScan is a brand name. So yes, FibroScan is a good test for liver issues. If your question is whether you have fibrosis, yes, then FibroScan will answer your question whether or not you have fibrosis of the liver. Yeah. Okay, I think that's it. Okay. Yeah, thank you.